Functional venous testing is complementary to ultrasound imaging of the peripheral vascular system. Dr. Rook explains different types of functional testing as well as its importance.
Well, functional vascular tests are things that we do when we want to screen for disease, we want to identify the presence of disease, or we want to identify the severity of disease. So people presenting with classic symptoms, pain with walking, which we think of as claudication, or with skin breakdown, or with anything that we suspect might be due to PAD or arterial occlusive disease, those are the patients that should have some type of functional testing. The main differences between functional testing and duplex scanning are that functional testing gives us information about the presence and severity of disease. The primary purpose of duplex scanning is to give us information about the location of disease. Now, duplex scanning does give us information about the hemodynamic effects, but there's no real good way to look at duplex scanning and tell from the way an artery looks how much impact that appearance is having on the function of the patient. So this is where we look at functional testing, which involves measuring pressures, looking at waveforms, sometimes exercising patients, doing things that let us tie all of those together and match them up with the patient's symptoms. Well, the advantages of duplex scanning over functional testing are at least a couple. The biggest is that everybody has a duplex scanner, and it's a technology we're very familiar with, and we know how to use it, and we know how to interpret it. Physicians know what they're getting when they order it. We feel very comfortable with the results of duplex scanning. Functional testing is a little bit less easy to come across in many centers, but it's very valuable as well. The disadvantages of duplex relative to function tend to be in the cost, because duplex requires relatively expensive equipment, and it requires relatively costly technologists to operate. So it's primarily in the cost arena where we have some issues with duplex. At Mayo Clinic, we have a long tradition of functional testing. We combine them in many cases with our duplex studies, but we also do them as single studies. We'll typically do about 30 functional tests in a day, some venous, some arterial. And as I say, in many cases we will combine those with duplex studies so that we understand not only the way a blood vessel looks, but what impact it is having on, what impact the problem is having on the patient.
With Susan as our guide, let's review 3 different types of functional arterial testing: ankle-brachial index, segmental, and pulse volume recording.
This section covers physiologic testing, also called functional testing or non-invasive flow studies. The physiologic exam is a method of indirect testing that utilizes blood pressure cuffs and continuous wave Doppler to acquire systolic pressure measurements of the extremities. In contrast to ultrasound, which allows us to directly visualize and quantify specific arterial lesions, the information obtained from the physiologic exam provides a global assessment of the limb, tissue perfusion, and the status of collateral circulation in the presence of arterial lesions that reduce pressure and flow. The diagnostic information obtained from the physiologic exam is often used to complement the duplex ultrasound exam. The goals of the physiologic exam are to provide a global assessment of the arterial inflow and outflow. We can also determine the anatomic significance of a lesion and determine the presence or severity of disease and the healing potential of wounds. From a surveillance standpoint, we can determine improvement or progression of disease and also determine the success of interventions such as angioplasty, stents, and bypass grafts. So let's begin this exam by first reviewing patient position and signs and symptoms. I like to have my patient lay still in the supine position for at least 10 minutes before beginning my exam. During that time, you can interview the patient and also perform a visual inspection of the limbs, looking for things such as ulcers, skin discoloration, And you can also palpate the pulses during that time. While you're interviewing your patient, you can ask things such as why the patient is here for the exam, if they have pain in their legs or cramping or tightness or tingling, or if they have rest pain. You might also include questions such as, have you had any stents placed in your arteries, or bypass grafts, or any other interventions? While the patient is resting, you can perform the visual inspection portion of this exam. Simply look at the limb and feel for temperature changes, look for areas of ulceration or skin color changes, and also reach down and feel for pulses. The equipment that you will need to perform this exam is the physiologic recording device and blood pressure cuffs of varying sizes. I prefer to use the 10 centimeter diameter cuff on the ankle and the 12 centimeter diameter cuff for the calf and thighs and the arms. And lastly, you'll need a continuous wave Doppler probe. The frequencies typically vary between 4 and 8 megahertz. Today we are using an 8 megahertz probe. The first step of this exam is to obtain brachial systolic pressures and ankle systolic pressures. We use the highest of the right and left brachial pressures to compare to the ankle pressures. Why do we do this? The brachial pressures represent systemic pressure or pressure at the level of the left ventricle. In a patient without significant disease, the ankle pressures will be the same or slightly higher than the highest of the brachial systolic pressures. This is due to increased peripheral vascular compliance and a decreased vessel diameter as you move distally within the arterial tree. However, a patient with significant arterial blockages that does not have adequate circulation by the collaterals to support the oxygen demand at rest will have diminished ankle pressures. And now we are ready to place the cuffs on our patient. I will bring out the cuffs that I need for this particular exam. In this case, the 12 centimeter diameter cuffs for the arms and the 10 centimeter diameter cuffs for the ankles. I'm going to start by wrapping the left ankle, placing the bottom of the cuff just above the ankle bone and the hose facing towards the patient's head over the soft tissue in the calf muscle, and pinching with your 2 fingers at the top of the cuff to ensure that the cuff doesn't slide down or become loose. Make sure that the hose is not on top of the shin bone, because that will cause discomfort to the patient upon inflation. The bottom of the cuff may be a little loose, which is okay. The top of the cuff is what's important. You want to barely be able to get 1 finger underneath. And I'll move on to place the cuff on the right ankle, same fashion. And both arms. Have the patient raise their arm up, again with the hose towards the patient's head, and make sure that the top of the cuff is tight. Again, don't worry about the bottom being loose. Make sure the top is tight and not over any clothing. Raise your left arm. Also be sure that the cuff is not over the elbow. Placing a cuff over bone will cause the systolic pressure measurement to be artifactually elevated. After connecting my air hoses, I will proceed to obtain the pressures. The remote control allows for freedom of motion, so I positioned my ergonomic chair near the patient's left arm. I've placed a line of gel in the antecubital fossa where I will put the Doppler probe to obtain the brachial systolic pressure. Applying the probe at a 45-degree angle to the axis of the arm and slowly sliding across the line of gel until you intersect the arterial signal. Looking for the strongest signal possible by sliding back and forth. Once you find this, you're ready to inflate the cuff and obtain the pressure. Be sure to go about 20 to 30 millimeters of mercury above where the arterial signal disappears before letting off of your inflate button. I'll wait for 3 good beats before freezing my waveform, and then I'll go back and mark it at the onset of the first strong beat. And the left brachial systolic pressure is 116 millimeters of mercury. Moving back to the right side of the patient, we'll now obtain the right brachial systolic pressure. I've already applied plenty of gel to the antecubital fossa, and I'll place my probe along this line of gel, sliding medially until I intersect the arterial signal. I have a good strong signal, so I'll inflate. Remembering to go 20 to 30 millimeters above where the arterial signal disappears, and then listen for the return. I wait for 3 good beats, and I'll go back to the onset of the first beat for a right brachial systolic pressure of 130 millimeters of mercury. I notice that I have a discrepancy between the right and left brachial pressures. I have 130 millimeters of mercury on the right and 116 millimeters of mercury on the left. I'd like to repeat the left brachial pressure one more time to make sure that this difference is real. This time I got a pressure of 127 millimeters of mercury. So the right and left brachial pressures are somewhat even at this point. We've repeated these pressures multiple times on both arms to ensure that they are pretty close to one another. I'm now ready to obtain the ankle pressures using both the dorsalis pedis artery and the posterior tibial artery. We'll obtain 2 pressures for each ankle. I will anchor the heel of my hand on the patient's foot so that I can move with the patient as the cuff inflates. The Doppler probe will slide across the line of gel that I've placed, trying to insonate the dorsalis pedis artery at the top of the foot. And now I'll take the pressure of the left ankle with my probe on the dorsalis pedis artery. After I hear 3 good beats, I will slide back and mark the onset of the first strong beat for a pressure of 145 millimeters of mercury. of the left ankle using the dorsalis pedis artery. I will repeat the process again of the left ankle pressure utilizing the posterior tibial artery at the medial aspect of the ankle, just behind the medial malleolus. I'm also going to switch hands and hold the probe with my left hand and position my fifth digit on the heel of the patient's foot. Okay, I've waited for 3 return beats. I'll go back to the first one. At the onset, for a pressure of 149 millimeters of mercury. So we have 2 pressure values of the left ankle. The posterior tibial artery yielded 149 millimeters of mercury, and the dorsalis pedis artery yielded 145 millimeters of mercury. So from here we will calculate the ankle-brachial index using the higher of these two, which is the posterior tibial artery, and dividing that into the arm pressure. The value of the ankle-brachial index on the left is 1.15. And now moving on to the right ankle, I'll repeat the same process, obtaining a right ankle pressure utilizing the dorsalis pedis artery first. Remember to anchor the heel of your hand on the patient's foot before placing the probe down. Three strong beats on the return. And place your marker at the onset of the first strong beat for a pressure of 151 millimeters of mercury. Now we'll do the same thing, repeat the pressure of the ankle utilizing the posterior tibial artery. I'll feel for the medial malleolus and place the probe right underneath that. And waiting for 3 strong beats, I'll place the marker at the onset again of the first strong beat for a pressure of 168 millimeters of mercury. So on the right side, we have an ankle pressure of 168 millimeters of mercury using the posterior tibial artery and a pressure of 151 using the dorsalis pedis artery. We will use the pressure obtained with the posterior tibial artery to calculate our ankle-brachial index, since that was the higher of the two. And our ankle-brachial index is 1.29. So let's review our findings of the ankle-brachial index that we just acquired. Our patient has a right ankle-brachial index of 1.29 and a left ankle-brachial index of 1.15. The normal range of values for the ankle-brachial index is between 0.9 and 1.4. Hence, our patient's right and left ABIs fall within normal range. ABI values between 0.9 and 1.0 are suggestive of PAD, and further assessment utilizing other imaging modalities is at the discretion of the referring physician. ABI values that are greater than 1.4 suggest that the vessels of the leg may be calcified due to medial calcinosis. This may cause falsely elevated systolic ankle pressures and ABI values. In this situation, toe pressures and toe brachial indices, or TBIs, should be obtained since the small vessels typically are not affected by medial calcinosis. This will be covered later in this section. Although the ABI is a quick and easy tool that we have to evaluate the lower extremity for PAD, we should be aware of the limitations of this exam. Falsely elevated ankle pressures due to calcified vessels or obesity, variability of measurements due to technique, patient position, probe position, and uncontrolled hypertension. The ABI has decreased sensitivity for mild disease. If you encounter an ABI of 0.9 to 1.0, it might be advisable to follow up with a lower extremity ultrasound of the arterial tree. The ABI does not localize disease within the limb, since the gradient is somewhere between the arm cuff and the ankle cuff. In this situation, a complete segmental exam would be prudent. We will demonstrate how to perform this next. Now we will proceed with the segmental exam. First, I'll show you how to demonstrate the cuff wrap technique on the left leg. We're using a 12 centimeter diameter cuff to apply to the calf. And the top of the cuff should be just below the tibial tuberosity, which can be palpated on the lateral aspect of the calf. You want to be sure not to cover the patella, because that will cause falsely elevated pressures. Relax your leg. On the low thigh, a 12 centimeter diameter cuff. It sometimes helps to have the patient bend their leg slightly, externally rotate. This allows the muscles of the leg to relax. And the cuff will fit much better in this position. For the upper thigh, we have a 12 centimeter diameter cuff, but note that this one is extra long. And it also has a firm board in it, which will help keep the cuff at the top of the thigh. Keep your leg relaxed. The top of this cuff should be at the crease of the groin. This is the proper placement for the four-cuff technique. I'm ready and in position to obtain the pressures of the calf and the thigh using the posterior tibial artery. You could insunnate any vessel below the cuff that you're measuring the pressure from. I'm choosing to use the posterior tibial artery because it was the higher of the two when we obtained the ankle pressure. Remember, the dorsalis pedis was a little bit lower. It's also easy access for my probe. So I place my probe near the medial malleolus, obtain a strong Doppler signal, moving my probe side to side. Make sure you're center lumen, and inflate. I'm inflating the calf cuff. Be sure to tell your patient that it might get a little tight and to let you know if they can't tolerate it. The right calf pressure is 140 millimeters of mercury. Next will be the lower thigh pressure. And that pressure is 183. And now the high thigh pressure. Notice that I don't have to move my probe position. Observe your cuff and be sure that it doesn't change position during the inflation. Okay. And this pressure is 224 in the high thigh. Now I would repeat the same process for the right leg. Let's go ahead and do that, and we'll come back and show you what those results are. Now that we've obtained all the pressures in the right lower extremity as well, we are ready to analyze our results. What we have found is that every pressure from every cuff in every segment is higher than the right brachial pressure. This is a normal resting exam. Let's discuss what an abnormal finding might be. Typically, we look for pressure gradients between the cuffs. If I had a pressure gradient between the high thigh cuff on my right thigh and the low thigh cuff on my right thigh, this might signify disease between these two cuffs. And the major artery that runs underneath these cuffs is a superficial femoral artery. So that would signify that there's superficial femoral artery disease. Other examples of disease might be a difference between the right brachial and the left brachial. If we had a lower right brachial pressure compared to the left brachial, that might signify disease in the upper extremity artery, or the subclavian, axillary, or even the innominate artery. If you have a gradient between the arm and the high thigh, that might signify disease in the aortoiliac tree. A gradient between the low thigh cuff and the calf cuff would signify popliteal disease. Gradient between the calf cuff and the ankle cuff would signify tibial disease. And if you did take a toe pressure and there was a gradient between the ankle cuff and your toe, that might signify small vessel disease. Typically, we use a pressure gradient of 20 to 30 millimeters of mercury. If that gradient exists, then you should strongly suspect that there is disease within that segment. This concludes our segmental pressure evaluation of the lower extremities. Now we will move on to demonstrate how to acquire waveforms. Now that we've completed our segmental pressure exam, we can capture waveform images that will be utilized to complement the information from the pressure exam. The first type of waveform is continuous wave Doppler. This we utilized when we were obtaining the systolic blood pressures, and we can also take pictures of these waveforms. The other kind of waveform is a plethysmography waveform. Plethysmography measures changes in volume. This usually results from fluctuations in the amount of blood or air it contains. In this case, we're performing pulse volume recordings, or PVR. Air is inflated into the cuffs, somewhere around 60 millimeters of mercury. The plethysmography device senses changes in limb circumference with arterial pulsations as air in the cuff is compressed or displaced. The pressure transducer in the plethysmography device translates pulsations into graphically displayed waveforms. The waveform fluctuations correlate with changes in volume of blood within the segment under the limb of the cuff. Let's begin the PVR exam by inflating both ankle cuffs to 60 millimeters of mercury. I'm adjusting the size so that my waveform fits about 3/4 of the screen. And I will wait for 3 or 4 consistent beats to move across the screen. and I'll save that. After we obtained our ankle PVR waveforms, we went ahead and acquired the waveforms in the calf and the thigh. Our findings show that we have normal PVR waveforms both side to side and up and down the leg. A normal PVR waveform has a steep upstroke, a sharp systolic peak, a narrow pulse width, and a dichrotic notch. You may even observe downsloping towards the baseline. Mild disease is displayed with a fairly sharp peak that is maintained. The waveform, however, broadens, and the dichrotic notch may be absent due to vasodilation. This is typically when there's more proximal disease. Also, the downstroke may be bowed away from the baseline, but not always. Moderate disease may show prolonged systolic upstroke and downstroke. There will be a reduced amplitude and a rounded systolic peak. Severe disease will be displayed by a markedly diminished amplitude, a significant delay in upstroke and downstroke. A flat line indicates chronic limb ischemia. In summary, we've acquired our segmental pressures and our pulse volume recordings. Continuous wave Doppler acquisition involves blind insunnation of the artery, and this must be recorded with a freeze and save function on your physiologic device. Moving around to the patient's foot, I'll first start with the dorsalis pedis artery. And remember, we use this artery to record the systolic blood pressure, so it should be pretty easy for you to find it again. Nice strong signal. Don't be too close to the edge of the vessel. Be in the center of the lumen. And simply freeze and save. Then you repeat the process for the posterior tibial artery. Moving the probe side to side to find the strongest signal possible. And freeze and save. We'll continue with the same process of waveform acquisition of the popliteal artery at the crease of the knee, the superficial femoral artery in the distal thigh, and the common femoral artery at the crease of the groin. The purpose of this is to qualify the continuous wave Doppler waveform. We want to know if it's either triphasic or multiphasic, biphasic with loss of reversal, or monophasic. This information will complement the segmental pressure exam. We went ahead and acquired all of our continuous wave Doppler waveforms of the bilateral dorsalis pedis arteries, the posterior tibial arteries, the popliteal arteries, the distal superficial femoral arteries, and the common femoral arteries in the groin. Our findings show that we have normal triphasic flow throughout both lower extremities. This is a normal exam. Now I'd like to demonstrate how to obtain a digit pressure. When tibial artery pressures cannot be accurately obtained, such as in the case of medial calcinosis, ulceration, or bandages over the ankle, you can utilize the toe brachial index to determine if there's a decrease in the circulation to the lower extremity. For this method, we'll use a digit cuff, and we'll use photosensing technology. This photosensor senses cutaneous flow. I'll wrap the digit cuff around the great toe with the hose pointed down towards the ground. This will allow me to fully wrap the cuff around the toe without having to reach in between the toes. Then I connect the air hose, and then I will apply the photosensing technology to the toe. Now, if you don't want to use a clip, like I'm showing you here, you can simply tape it to the toe. So instead of listening for Doppler, we use the visual on the screen to take our blood pressure. We want to make sure that we have a nice waveform that's big and easy to see running across the screen. And then when you're comfortable with what you see and it's stable, go ahead and inflate the cuff. Inflate until the waveform completely disappears. And watch for the return. Remember, this is purely visual. There's nothing to hear. It's simple observation of the return of the waveform. Moving back to the onset of the first upstroke, we have a toe pressure of 97. And that gives us a toe brachial index of 0.75. A normal toe brachial index is greater than 0.7. Our patient has a normal TBI. We have now completed our physiologic exam of the bilateral lower extremities. To overview, during this exam, we've learned how to measure ABI, measure segmental pressures, acquire PVR and CW Doppler waveforms, and finally measure digit pressures. The physiologic exam provides pressure, directional, and volume flow studies to confirm hemodynamically significant disease of the arteries. It defines involved segments. It provides important functional capacity and how it relates to clinical presentation. And finally, it assesses response to therapies and interventions. Remember, the physiologic exam should be utilized to complement the lower extremity arterial ultrasound examination.
As we've learned, together with ultrasound duplex, functional arterial testing allows us to paint a complete and vivid picture of the patient's arterial pathology. As both modalities evolve, how will functional testing progress in the next 5 to 10 years? Dr. Rook shares his perspective.
I see functional testing progressing over the next 5 years and 10 years in ways that are going to be dependent upon, I think more than anything else, reimbursement. In our current fee-for-service environment, there's no question that duplex scanning is the king of vascular technologies. But as we start to get away from fee-for-service in the future and we start aiming more towards value-based compensation, I believe that we're going to see an uptick in functional testing, largely because it's simple, it's cheap, and it's very easy to disseminate throughout a system. In fact, as hospitals are now beginning to acquire practices that are peripheral to them that they need to link with, functional testing offers a very, very simple and easy way to connect practices at a distance with each other.
Regarding the venous system, functional testing commonly involves plethysmography, or a measure of volume changes. Dr. William Marston explains different types of plethysmography as well as its utility in the venous field.
Well, plethysmography, in our opinion, is an important adjunct in patients with complex venous disease to duplex ultrasound. So for the vast majority of patients, you get the information you need from good ultrasonography. But there are times when the symptoms and the findings on ultrasound don't really match, or patients may have complicated findings. And in those patients, we think plethysmography can be very helpful. It gives you a hemodynamic measure of the function of the leg that ultrasound or axial imaging can't do. So it really tells you how quick does the leg expand when you place it in a dependent position, or how much does the volume change when you pump the calf muscle. So it's a measure of performance with maneuvers that you can't get from ultrasound. I wouldn't really say advantages or disadvantages compared to ultrasound. It's more of an adjunct in patients where you need it. There are different types of plethysmography. One is photo plethysmography, which uses a single point sensor that is placed at the ankle level and gives you measurements of volume changes. And the other is an air cuff that is placed on the leg between the calf and the ankle, and that also gives you volume changes. We personally believe at our center that the air is a bit more accurate, but others prefer photoplethysmography. So I think there's two situations where we get plethysmography. One would be a patient who comes in and complains of symptoms, but the ultrasound findings are normal. So plethysmography, which then measures volume changes in the leg, can give you an idea of whether there are abnormalities in the way that the patient's leg is behaving when they maneuver into different positions or when they use the calf muscle pump. And that can give you a global idea of whether there's venous dysfunction or not. The second situation would be when you have multiple systems where the veins are dysfunctional, and the APG or PPG can give you an idea of how bad that is altogether. Then if you do an intervention and treat them with ablation or some other modality, you can repeat the test and it'll tell you how much better your intervention has made their leg.
Let's review air plethysmography performed and commented on by Dr. Laurie.
Air plethysmography, or APG, is the test that measures changes in the volume of the leg over significant time intervals and during different maneuvers. Because this change in the volume mostly due to the change in the volume of the veins, we are able to measure venous outflow, reflux, and the function of the muscle pump. During the first part of the test, which calls occlusive plethysmography, patient is supine, the measuring cuff is positioned in the cuff of the patient, and the tourniquet is positioned on the upper thigh. The pressure in the tourniquet is increased to about 80 millimeters mercury, which is slightly above the pressure in the arterial system. During this time, blood is coming into the leg but cannot escape venous system because of the tourniquet. After the blood reaches the plateau, we suddenly relieve the pressure in the tourniquet. That leads to decrease in volume from that point towards the end of the test. It's important to know that that point when the pressure is relieved from the tourniquet, the pressure in the entire venous system of the leg is about 80 millimeters mercury, and the pressure in the iliocaval system is close to zero. That allows us to calculate the resistance of the segment. The measure that usually used for assessment of outflow is outflow fraction, which is the volume of the blood that escaped the venous system during the first second after deflation. For the second part of the test, we elevate patient's leg. The blood is flowing from the venous system of the leg. It is important to keep the knee slightly bended so the tibia does not compress the popliteal vein. As blood exits the venous system of the leg, the volume of the leg decreases to the minimum point. At this point, patient stands up, putting all the weight on the contralateral leg. Gravitational forces push the blood towards the veins of the calf, and the calf veins volume increases. We wait a few minutes, and the blood volume reaches its maximum level, at which point we measure maximum venous volume. At this point, patient puts all the weight on both legs and performs one tiptoe movement. It tests the muscle cuff. During that movement, the volume initially increases and then drops because of the action of the muscle cuff pump, and slowly returns to the maximum venous volume. After that, patient performs 10 tiptoe movements. The volume of the calf progressively decreases, especially during first 2 or 3 movements, and then stabilizes at the one level. After that, patient returns in the horizontal position with the leg slightly elevated. At the completion of the test, we have the curve that reflects the entire volume changes in the leg. You can see increase in the volume while patient standing up. The time for this increase depends on the amount of reflux in the leg. The more reflux the veins have in the leg, the shorter is the time. So that time is used to calculate venous filling index, which is the measure of venous reflux. The volume that ejects from the vein during the muscle contraction is used to calculate ejection fraction that reflects the function of the muscle pump. As you can see, APG is a physiological test, allowing us to estimate the venous outflow, global venous reflux, and the work of the muscle pump.
How will plethysmography progress in the next 5 to 10 years? Dr. Marston shares the hopes he has for this type of testing.
Well, in the next 5 or 10 years, my biggest hope with plethysmography is that more centers use it. It's really a minority of centers that use it because it's not the thing you use to diagnose every patient. But I think for the types of situations we've talked about, it can be very helpful in choosing the best treatment for patients and telling how much treatment you need to do. So for instance, if you take that patient that has complex disease and you treat one of the 2 or 3 venous systems that are abnormal and your PPG measurements get much better, then you probably don't need to do any more treatment. And so hopefully more centers will start using plethysmography.
Modern technology allows us to use alternative ultrasound modalities in order to improve our visualization of the peripheral venous system. Although new to its adapters, one advantage of modern technology includes increased resolution. Dr. Antonio Skisparis describes the utility of one such technology, intravascular ultrasound.
I've been an early adapter of IVUS, or intravascular ultrasound, in my practice, and I've dedicated venous practice right now. And I found that IVUS has really revolutionized the diagnosis and management of patients with iliac obstruction. IVUS is a tool that we use in the situations where patients are a diagnostic dilemma, or even if we do find a lesion. So patients who have a confirmed lesion with non-invasive imaging, especially patients with C class 3, 4, 5, or 6. So clinical class of swelling, skin damage, or ulceration. So in this situation, we either have a confirmed diagnostic imaging modality that there is a lesion and we are intervening, or their imaging is non-conclusive or not available, and we proceed with IVUS as a diagnostic modality, and if we do find a lesion, then we use it as a tool to guide us for intervention. Ultrasound is a great tool for diagnostic purposes, and IVUS compared to ultrasound, some of the disadvantages is that it's an invasive test. Unlike a regular ultrasound, it's a non-invasive test. So obviously that's a major advantage of regular ultrasound and a disadvantage of intravascular ultrasound. On the flip side, IVUS allows you in some situations to identify lesions that regular ultrasound does not. So it may have a better way of identifying disease. The other disadvantage, obviously, depending on each center, if your regular ultrasound technologist is not trained appropriately, they may miss disease. So IVUS allows you to pick up disease, obviously, in those situations. Another advantage of IVUS is that it allows you to guide you for intervention. So if you do find a lesion, you can treat the patient at the same time.
For reference, we will correlate multiple intravascular ultrasound and venography images with Dr. Laurie.
Other venous images. Although we rarely use venography anymore, some pathological condition requires its use. An example is popliteal vein entrapment syndrome. You can see on the image on the left that the popliteal vein is open and the blood goes through the deep veins freely. However, when the patient dorsiflex, the blood stops in the popliteal vein and goes through the superficial veins. Dynamic venography allows you to see it in action. You can see the filling of the popliteal vein and disappearance of this filling when the patient dorsiflex. Intravascular ultrasound, or IVUS, is another ultrasound modality, but it is invasive. The crystals are mounted on the tip of the catheter that's inserted inside the vessel. You can see on IVUS the lumen of the vessel, the surrounding tissue, as well as the masses inside the vein in a chronic venous disease. IVUS allows us to identify intraluminal structures, extraluminal changes like fibrosis and post-thrombotic disease, but most importantly, it makes possible to measure cross-sectional area of the vessel. As the catheter is withdrawn from the vein, you can measure and see the changes in the venous lumen. And so it's the only one modality that we can use to objectively measure the degree of the venous stenosis.